Thank you very much. Yes, and thank you for this invitation to take part in this wonderful series. I just wrote to Tom, I don't feel distinguished at all. I needed to look it up in the dictionary what it exactly meant. And as you can hear, English is not my first language. I'm sitting over in Denmark, Scandinavia, and I hope you are able to understand what I say, or else you'll have the chance to ask me afterwards. So I have called this presentation, How Can We Make Communication Everyone's Business? And I will share some experiences from implementing partner training, communication partner training in hospitals. And looking at some of your faces and names, that makes me nervous because many of you have done this for so many years before I started doing it, and I owe you a lot. Yes, can you see when I change the slides now? Yes, good. So a few disclosures. We don't do that very much here in Denmark, but I thought I should do a few of the formal ones and then some informal disclosures. So I'm employed at the University of Southern Denmark, when that's where I receive my salary from. I'm a board member in the Aphasia Access and in different Danish boards, and all that is unfunded, not the job at SDU though. Some of the research mentioned in this presentation is funded by either my university or a foundation called Trygfonden. Much of what is presented here today is made in collaboration with fellow researchers and clinicians, and also much of what is presented here today is not yet published in English. I have some in Danish, I have a few references on, and some is close to be submitted. And then you probably know, but probably don't know how big a difference there is between the US and Denmark. We are a very small country with only close to 6 million people, so it's very hard for me to sit here and give you good ideas, because I know it's much easier to get the ideas and carry them out here in such a small context. And also our SLP workforce is very small. Actually, I would know many of them working in the sphere of aphasia, and that means it's also much easier to perhaps get an impact and try sort of to get clinicians involved in the research going on. We don't do as SLPs any dysphagia management, so that also means when we work in hospitals, we can work with communication only, and that's also quite a big difference. On the other hand, we have hardly any aphasia research in this country. My former colleague Lisa Jensen retired last year, and we have a few PhD students both here in this university and in the University of Copenhagen, which are the only two university programs, but they are not working on aphasia, but on TBI and issues like that. So my plan for today is to share a few insights from Denmark related to communication partner training of health professionals in hospitals. And I also have a few slides with some of the barriers and facilitators that we have identified over the years for making communication everyone's business. And then, of course, we will spend quite a bit of time sharing experiences, and if you have any questions for me or comments, I'm happy to engage in them as well. So, on to the topic of today. So I thought I would just make a little definition of CPT, or communication partner training, before I really sort of dive into the topic, just so that we are on the same page. I have chosen this definition from Simons-Maggie et al.'s latest review paper, but it could also have been other definitions that are more or less the same. So CPT is a form of environmental intervention in which people around the person with aphasia learn to use strategies and communication resources to aid the individual with aphasia. Therefore, this evidence-based approach to improving communication involves training people other than or in addition to the individual with aphasia. The intent is to improve the functional communication, participation, and well-being of the person with aphasia. Communication partners include people with whom the person with aphasia might interact. So, for example, family members, caregivers, friends, and healthcare providers. And for this presentation, we will talk about the training given to healthcare providers, and it will also be training where that doesn't involve people with aphasia. So more generic type of intervention that we can give to bigger groups of healthcare professionals. And when I need to summarize, so what is the purpose of giving CPT? I also have another slide related to that though. But as I've written here, CPT is a part of making services, the environment, or simply life more accessible to people with aphasia, and not just the mechanics of teaching communication partners something. It should not stick with them. They should use what they have learned and they should bring it on, support people with aphasia, and in that way make a difference for them. So why is this necessary then? Most likely I'm preaching to the choir today is my guess, since it's Aphasia Access that have put on this presentation. But I think there are many motives, and some of them being, it could be in the local legislation. I know you have some bills in the US for sort of communication rights and access and so forth, not that I'm very familiar with that. It could be the current ethos, ethical and democratic motives for doing person-centered care, involvement, shared decision-making. At least that is something that we hear a lot here when it comes to healthcare, that it's important to have patient-centered, person-centered healthcare. It's important to involve them in decisions and so forth. And then there's the UN Convention on the Rights of Persons with Disabilities from the UN. And they have a full article, a full chapter on accessibility that also says that people with disability have the right to get involved in all sorts of services, including healthcare. And we might be okay with that to a certain degree with some disabilities, like at least here when we do a new public building or renovate an old public building or whatever, then it needs to be accessible in terms of ramps for wheelchairs and elevators and so forth. But when it comes to accessibility for people having a communication issue like aphasia, that's not so much the same. We have ratified the convention here in Denmark. I know it's not ratified in the US as far as I could look it up, but I guess many of you will orient yourself to it anyway. Then we have clinical guidelines. This is probably not the newest one, but this is from the Canadian stroke guidelines, saying that all team members should be trained in supported conversation to be able to interact with patients with communication limitations such as aphasia. We have similar in Denmark. I know there are also other guidelines from Australia and elsewhere. So but I'm not quite sure if it has reached guidelines in the US. And then we could have personal motives like being a better clinician, being able to communicate with my patients. And we also have evidence from the research literature that might motivate us to think communication partner training is a good idea, because we know lots of results from the literature saying what bad health communication can have of crucial consequences for patients, for staff, for the economy in the hospital, for instance. So we see more adverse events, we see lower adherence to treatment, and so forth. So, I don't know if you know the man here in the corner. This is Hans Christian Andersen, the fairy tale writer. He was actually born here in Odense, where the university is, and he's here sitting as a sculpture in Central Park in New York. And I think we have been writing a bit of a tale or a fairy tale, not a fairy tale, because it's a true story in Denmark. And sometimes I have also with Lisa, my former colleague, been speaking about the case of Denmark playing with the SCA abbreviation. And or I can see you are here and you are very much a part of this. To tell you a little bit about the timeline here, in the mid 2000s, mid zeros, I don't know what you call it. The first Danish SLTs started to travel to Canada to receive the SCA training, supported conversation for adults with aphasia, at the Aphasia Institute in Toronto. And I have taken the pictures here. So Aphasia Institute has a big map in their hallway where people getting trained put in their pins. And as you can see, it's a bit crowded around here. And this is a closer shot. And lots of pins put in this tiny little country called Denmark. And but not really until 2011, it really started to get some impact, because Lisa Randrup Jensen at that point got to write a few things into an evaluation after acquired brain injury that the Danish health authorities were making. And what she put in there was that there was some reasonably good evidence for training the communication partners of people with aphasia. And she was referring to the leg study from South Africa and also to Ora Kagan's own study of training volunteers. And after that, my guess is that some of the different managers of neurological wards saw that and thought, well, we want to jump onto this. We want also to make an impact for those people. Here is perhaps a chance that is not really that much explored or fairly unexplored. We should do something. And especially one hospital, and that is what I referred to here, decided we want to train all of our staff. So they sent people to Canada to receive training, went home, made a study. Lisa Randrup Jensen was employed in that study. They also had a thing like an SCA speech pathologist in charge of all issues around CPT. So they made a really big push. They also published quite locally, like in the magazine for nurses, in the magazine for OTs and PTs, and in that way, sort of the rings were spreading. And that same hospital also succeeded in making an internal guideline around the use of SCA. And eventually that was also recognized elsewhere in the region of capital region of Denmark. And later on, it made into SCA, or not SCA specifically, but supported conversation, made it into new recommendations from the Danish Health Authority, and they recommended CPT to be used when, or not CPT, but supported conversation to be used when healthcare professionals were communicating with people with aphasia. And then I have stopped it here, and it was because Lisa and I made a little study at this point in 2018. And at that point, 12 hospitals had trained their staff in SCA, and with 9 more planned around 2018-19. Not just SCA, because I have also been involved in like a further development of CPT into a Danish training context. I'll not say a lot about that, but I'll mention it later on. So here's a map of Denmark. So the green spots, that was before, up till the study we made in 18, and the red ones has been doing their training since. And since our study stopped at that point, I can only give you anecdotal evidence of the gaps we have in 2022. And as far as we can see, there are still 2 to 3 major acute wards, not having done any training to private rehab hospitals. And I'm sure some of the places could need some re-implementation. And we already knew from the beginning back in 2018 that a few of 2 of those hospitals that reported in to be green, that they only trained less than 10% of the staff. So, and if you are, I'm living over here with the red spot on the west coast, but I'm sitting here in the middle of the country in Odense, and we have a big, nice university hospital, and they have not been doing any CPT with their staff. So hopefully one day we'll be able to raise some funds and do some training there and do a study of it as well. So a few facts related to that study. So we did a survey, as I said, back in 2018, and we disseminated it at 2 conferences that year. And it was with the 12 hospitals I have already been telling you about. I just need to figure out and keep my time support. So at the moment, more than 50 SLPs were trained at the Aphasia Institute in Canada. They have trained more than 1,500 staff, 7 sites at this point. It was close to 100% of the relevant staff that were trained at 3 sites. It was 60 to 80%, and in 2 sites, it was less than 10%. Usually all professions were trained. Some places also secretaries, service workers, porters. 3 sites also mentioned training students of all kinds of professions. 1 site mentioned training volunteers from Red Cross, and another place trained the hospital pastor. And actually, quite funnily, I have a master's student that have done a completely other study, not related to CPT, but about spiritual care this spring. And up pops this hospital pastor that has been trained, because apparently she had some good skills to go in and provide spiritual care also for people with aphasia. So that was a nice little proof somewhat of the training works somehow. So the training ranged between half an hour, and that small amount of training that was related to those 2 sites, not training very many. And up to 2 times 6 hours. Often the training was divided into 2 modules, and many followed the structure from the Aphasia Institute. The content was mainly of the training was mainly related to methods to support conversation. So not a lot about what is aphasia and things like that, maybe a little bit, but mainly sort of focusing on giving people skills to go out and communicate and support communication. And very interestingly, the initial training was partially funded from 2 grants, only at 2 sites. The rest was either funded through the regular budget or with money for continued professional development, just to really underpin it. You don't necessarily need big money to be able to do something. Perhaps you are able to get started without any funding. And some of our conclusions from the 2018 study is that the implementation of supported conversation for adults with aphasia in the Danish hospitals has often started from the grassroots. We see that it was staff, either because they read something in the nursing magazine, or it could be the SLPs having attended a course in SCA in Canada, coming home saying we want to do the training. So not very often a top-down approach from the manager saying we want this, but more often bottom-up, and then convincing the management that this is a good idea. It can be good. It can also be bad. You certainly need the support from the management in order to be able to do a good implementation of the program as well. Therapists are more likely to use supported communication than care staff, and especially doctors are reported not to use the strategies if having attended the training at all. More support is needed from staff and management, despite good agreement about their support for using supported conversation. And the sites face, at this point in 2018, some of the same challenges at this point. And it was things like SLP time to support staff during the daily work, like time to go in and follow a training session, a bathing situation, or whatever. Large staff turnover, the need to have follow-up training, knowledge about implementation, more materials, support materials, and more networking with other sites. But very interestingly and very gladly, the responding sites agreed that being a patient with aphasia on the ward is easier now than before training. We do need to ask people how they felt. It wasn't done at that point, and I'm involved in a study a little bit looking at that now. And since 2018, what has happened then? Well, the SLPs continue to train and implement CPT in hospitals and elsewhere, like care facilities. We have an annual network meeting for SLPs and others interested in CPT. We share knowledge, we share if some sites have done a little bit of research or whatever it could be. And we have just had a meeting here in April, and it's very inspiring to see what's going on out there. Then I have been involved with the colleagues here in developing a questionnaire, a self-reported outcome measure for health professionals participating in CPT, so that we can perhaps use it in data studies, and the clinicians can also go in and use it. I have been involved in co-creation of a CPT program called COMTIL for health professionals, and it's tailored to a Danish context, where we have kept in mind that we start in a regional setting in hospitals, and then we continue to maybe more inpatient, and then also some outpatient services in the municipalities. And we have been co-creating the program with people with aphasia, significant others, and healthcare professionals. And it's not a huge difference compared to SCA, but there are some differences. Then we have over the last few years, that program of research has been completed now. So we are writing up 2 papers about how people with aphasia are experiencing supported conversation in a hospital context. And hopefully we will have some kind of adapted version of this new COMTIL, it's not that new, but our Danish COMTIL program for significant others. At least that is what we have in our mind with a new study we just started here in January. And then other researchers in Denmark has also been doing research in CPT related to other patient populations, Anne-Sophie Nielsen and Eden Christensen's PhD study, and they're both about TBI and CPT. So a few barriers for making communication everyone's business. And I hope we could evolve our conversation also around both the barriers and facilitators, if you want. So that could be the usual suspects, as I called them: time, staff turnover, funding, things like that. It can also be very hard to address for the people attending the training. What is in it for me? Why should I attend this course? Why should I change the way I communicate? I think it works quite well. I'm good at this already. I don't need more information about this or whatever it could be. Because we do compete with many other need to do procedures on a busy ward. And some, as I've already said, some health professionals and some health professional groups are seem to be better to support communication than others. That's what we hear, but it's not something we have investigated. And then there's also an issue of the right people not understanding that training is not enough. We can train, but we also need to have a lot of support to underpin that training. So we need, for instance, support materials at the ward. We need to be able to train new staff at the ward. We need to be able to keep the kettle boiling. So maybe some follow-up training or whatever it could be. And then a few facilitators for making communication everyone's business. I think it's important to share the evidence we have for this. And I'm thinking about the evidence for CPT, but also the evidence for what bad health communication is doing to our patients and to us for as clinicians as well. And I have found it has been quite powerful when you want to start to work with a ward, that they truly understand and appreciate that there is good evidence behind this. And then I think we could also work on the democratic and ethical motivation for going into CPT. Health professionals want to be involved in their own healthcare. I do. I don't want my doctor to take decisions on my behalf, and I think we can all understand that. But we also need to carry it out when we are the healthcare professional there. And I have already indicated, do not think that training is enough. We need support materials to go with the training. Perhaps we need new ways of having meetings and to organize different practices at the ward. And do not be afraid to involve other health professionals. It could be as champions. It could even be as trainers, and that's actually one of the new additions to the COMTIL program. We have been training nurses and physios and OTs and nursing assistants as well to be COMTIL trainers, so they can go out in their own organization and train their peers instead of a more remote SLP going out and doing the training. And then, of course, there's the resource issues. If we do have money for training, yes, perhaps it's easier if there is set time aside for CPT training, but also to actually be able to support the person with or the patients with aphasia in the daily life on the ward. That is also a good idea. Sorry, I've been speaking too long. This is it.